I'll be presenting the interim results of the AMPLIFY trial on behalf of my co-authors. These are my disclosures. Patients with treatment-naive CLL have several treatment options, including continuous BTK inhibitor therapy, fixed-duration Venetoclax-based regimens, and chemoimmunotherapy for low-risk patients. While fixed-duration Venetoclax plus Ibrutinib, a first-generation BTK inhibitor, can result in deep, durable responses, cardiac toxicity remains a concern, particularly in older patients. Acalabrutinib is a highly selective second-generation BTK inhibitor with improved safety and tolerability compared with Ibrutinib in a head-to-head trial. Here we report the pre-specified interim analysis of the phase 3 AMPLIFY trial that assessed the efficacy and safety of fixed-duration Acalabrutinib Venetoclax with or without Obinutuzumab compared to investigators' choice of chemoimmunotherapy in fit patients with treatment-naive CLL. Here's the study design. 867 patients were enrolled. They were treatment-naive and met criteria for requiring treatment according to the IWCLL 2018 criteria. They did not have 17p deletion or p53 aberration, and they had low-risk comorbidity scores. They were randomized between 14 cycles of Acalabrutinib Venetoclax, or AV, 14 cycles of Acalabrutinib Venetoclax Obinutuzumab, or AVO, or 6 cycles of either FCR or BR, according to investigator choice and fitness. Crossover was not allowed. The AV and AVO dosing schedule is shown at the bottom. Patients began with Acalabrutinib for 1 cycle. Those who were receiving Obinutuzumab started it in cycle 2, and Venetoclax was ramped up in cycle 3. Acalabrutinib and Venetoclax were then continued together through the completion of 14 cycles. The primary endpoint was IRC-assessed progression-free survival comparing AV to chemoimmunotherapy. If this primary endpoint was met, secondary endpoints were tested in a fixed sequential hierarchy shown here, beginning with IRC progression-free survival for AVO compared to chemoimmunotherapy, followed by undetectable MRD for AV, then AVO versus chemoimmunotherapy, and finally overall survival for AV, then AVO versus chemoimmunotherapy. There was no planned comparison between AV and AVO. This slide shows the primary endpoint. IRC-assessed progression-free survival comparing AV to chemoimmunotherapy was positive, favoring AV with a hazard ratio of 0.65 and a 3-year estimated landmark PFS of 76.5% compared to 66.5% for chemoimmunotherapy. The next evaluated endpoint was IRC-assessed progression-free survival for AVO compared to chemoimmunotherapy, which was also positive with a hazard ratio of 0.42 and a 3-year landmark estimated PFS of 83.1% for AVO compared to 66.5% for chemoimmunotherapy. Rates of undetectable MRD at a level of 10 to the minus 4 measured in peripheral blood at end of treatment in evaluable patients were 45% for AV, 95% for AVO, and 72.9% for chemoimmunotherapy. Progression-free survival was improved with both AV and AVO, regardless of IGHV status. And particularly noticeable is the fact that in the AVO arm, those patients with unmutated IGHV are doing as well as those with mutated IGHV, suggesting that the addition of Obinutuzumab may overcome the adverse impact of unmutated IGHV. In terms of overall survival, in the primary analysis shown on the left, overall survival was prolonged with AV compared to chemoimmunotherapy. And in a pre-planned analysis censoring for COVID-19 deaths, overall survival was prolonged with both AV and AVO compared to chemoimmunotherapy. Of note, this study was conducted at the height of the pandemic, and COVID-19 deaths were seen in 10 patients on the AV arm, 25 on the AVO arm, and 21 on the chemoimmunotherapy arm. In terms of safety, the most common adverse event was neutropenia. Any serious adverse event was seen in 25% of the AV patients, 38% of those receiving AVO, and 27% with chemoimmunotherapy. In terms of cardiac events, 9.3% of AV patients and 12% of AVO patients had some event, compared to 3.5% of those receiving chemoimmunotherapy. Atrial fibrillation, however, was low at 0.7% for AV, 2.1% for AVO, and 0.8% for chemoimmunotherapy. Hypertension was also low at 4% of the acalabrutinib-containing arms compared to 2.7% of the chemoimmunotherapy arms. So in conclusion, AMPLIFY provides the first phase 3 evidence of fixed-duration therapy with a combination of Venetoclax and a second-generation BTK inhibitor in patients with treatment-naive CLL. This interim analysis of AMPLIFY with a median follow-up of 40.8 months in fit patients with treatment-naive CLL demonstrated a significantly improved progression-free survival with fixed-duration AV and AVO compared to chemoimmunotherapy, including in the unmutated IGHV subgroup. Rates of undetectable MRD were highest in the AVO arm, and overall survival was prolonged with AV compared to chemoimmunotherapy in the primary analysis, and with both AV and AVO compared to chemoimmunotherapy after censoring COVID-19 deaths. Both AV and AVO had tolerable safety profiles with a low incidence of cardiac adverse events typically associated with BTK inhibitors, including atrial fibrillation or hypertension. Thank you for your attention, and I'm happy to take any questions at the end.
Thank you, Dr. Brown.